Okay, so complications that can occur in labor versus premature labor and delivery. This is labor or delivery between 20 and 36 weeks, 5 days. Okay. Viability begins about week 23, 24. So we can have babies delivered at 20 and 21 weeks that are not viable, but it's considered preterm delivery, not a miscarriage. It's very difficult to predict. There are a lot of risk factors, but a lot of the mothers who have preterm delivery don't actually have any risk factors. And a lot of parents, a lot of moms who have preterm labor don't go on to deliver. One of the biggest predictors is ever having had another preterm delivery. Management, bed rest has not really been shown to be effective, and it increases some other risk because we have the risk of immobility. Hydration is the most effective because dehydration and UTI contribute to preterm labor. So sometimes if they're having contractions, we hydrate, it gets better. There are some medications that are sometimes used for preterm labor, but they're the most helpful in allowing enough time to get steroids in to promote lung maturity. So we have a patient who comes in contracting. If we give meds and those contractions stop, most likely that patient was not going to deliver anyway. If the patient comes in and we give meds and they're going to deliver early, the contractions probably won't stop when we give those meds. So meds are not very effective at preventing preterm delivery. What they are effective at sometimes is delaying it long enough to get some steroids in. So the meds that might be used, terbutaline is an adrenergic agonist, so it relaxes the uterus, but it also causes racing heart, jittery, causes the fetal heart rate to go up. It may cause higher blood pressure, but if the heart rate gets fast enough to decrease filling, it causes lower blood pressure. Nifedipine is a calcium channel blocker that relaxes smooth muscle. It may also lower blood pressure. It can delay delivery by a couple of days. Magsulfate used to be given to delay delivery. Now it's given in preterm labor before about 32 weeks to try to prevent cerebral palsy, but it doesn't, none of these have an effect in preventing delivery. They can, however, delay delivery long enough sometimes that we can get a dose of betamethasone in. Betamethasone is a corticosteroid. It's given as an IM injection to the mother, and it accelerates lung maturity. It has a really big impact. It was actually a game changer for preterm delivery. The next one we want to talk about is PROM and PPROM. PROM stands for premature rupture of membranes, but they're not preterm. The premature means before labor. PPROM means preterm premature rupture of membranes. So again, there are a lot of things that can contribute to this: infections, having more fluid, having multiple pregnancy, having some trauma. There are a lot of things that can contribute. What are we worried about? If the membranes rupture and the patient is not in labor, the biggest risk we're worried about is infection. It can also lead to preterm birth if they're preterm. That infection can lead to maternal sepsis. It can lead to fetal sepsis and intrauterine fetal death. If we lose the cushion of that fluid, we can have cord compression. When the water breaks, it can wash the cord out with it, so we can have umbilical cord prolapse. It can trap the fetus in an awkward position, a malpresentation that's hard to deliver, and it can lead to respiratory distress syndrome. Okay, management. Typically, if water breaks, they don't try to stop contractions. But if they're preterm, they probably don't try to induce labor and speed it up either. They just wait it out. Antibiotics are going to be given routinely. Vaginal exams are avoided until the patient is in labor. The patient's advised to do pelvic rest. If they're preterm, they get betamethasone. If they're near term, they go ahead and induce labor. If they're preterm, they would induce labor if they start showing signs of infection. So this patient is inpatient and monitored. So what would it look like if they were developing an infection? The first things you're going to see are maternal fever and increased fetal heart rate. Okay. A post-term pregnancy is greater than 42 weeks. It's more likely to happen over 35 and with the first baby. Complications, they're more likely to be induced, more likely to have a C-section. The baby may have had time to get larger and more difficult to deliver. They can lead to a lot of anxiety. The placenta starts to age and not perfuse as well, so they can have decreased placental perfusion, which can lead to oligohydramnios, and it can actually lead to fetal weight loss, but what they're losing is fat and muscle, so the baby may still be hard to deliver if their skeletal growth has been too much. It can cause meconium staining, so they pass meconium in the uterus, and that puts them at risk for aspirating that meconium at birth. It can lead to non-reassuring fetal heart rate because the placenta is just aged too much to be able to tolerate labor. It can lead to intrauterine fetal demise. When that baby is born, they're at risk for hypothermia and they're at risk for meconium aspiration if they pass meconium. Management, they're going to monitor this pregnancy with BVPs and NSTs, but mostly they're going to try to get this baby delivered. We're going to talk about two more in this section, and then we'll move to the next section. Another complication we look at is retained placenta. That's the placenta is not delivered 30 minutes after birth. The complication of that is hemorrhage. If we can't get the placenta out, especially if it's partly detached, they can be hemorrhaging. Management, the provider may remove it manually or surgically. Sometimes there's an abnormal implantation. It's actually grown into or even through the uterine wall or even into surrounding structures. If that's the case, then removing it surgically may mean they need a C-section, and they may even need to do a hysterectomy if they can't stop the bleeding. We would be monitoring that patient bleeding and fundus and monitoring them for infection. Meconium stained amniotic fluid is when the fetus passes meconium, that first black tarry looking stool in utero. It's more likely to happen if they're post dates, in a breech birth, or with fetal hypoxia. Fetal hypoxia can relax the sphincter, cause them to pass meconium. Complications. The major complication is the fetus aspirates the meconium, and it can cause meconium aspiration, which is an ARDS-like illness. It's like a chemical pneumonia. Management. Okay, in the notes it says amnio infusion to thin that meconium in labor. That's no longer recommended. It wasn't found to be helpful. So what happens when that baby is delivered, if they're unresponsive, they suction them before they start resuscitation. If that baby's born and they're responsive, you do not delay resuscitation to suction them. You just clean the mouth and nose out with a bulb syringe and observe them for respiratory distress. Okay, in the next section, we're going to talk about some emergencies.